Welcome everybody. If I could go through the members of the board and introduce, and then when we come on to the items, if people could introduce themselves as and when they are speaking to the item. So if I can start with Councillor Greenwood, please, if you could introduce yourself.
Hello, yes, I'm Councillor Greenwood, Chair of Health and Social Care Overview and Scrutiny Committee in Bradford.
Thank you. Councillor Hargreaves.
Hi, I'm Councillor Hargreaves. I'm also from Bradford. Unfortunately, my connection is not stable enough to do video, or I'll lose connection again.
That's great. Well, we can hear you, so that's great. Councillor Hutchinson.
I'm Councillor Colin Hutchinson from Calderdale.
Thank you. Councillor Smage.
Councillor Liz Smage from Kirklees.
Thank you. And Councillor Rhodes.
I'm Betty Rhodes from Wakefield, Chair of the Scrutiny Committee.
And Councillor Clark.
I'm Jim Clark. I'm councillor from North Yorkshire.
Thank you very much. And I think, and we'll hear other apologies, and I'm Councillor Helen Hayden, Chair of the Adults Health and Active Life Scrutiny Board in Leeds and Chair of this committee this morning. So if we could go to the agenda, and number one, apologies for absence and any substitutes.
Good morning. I believe we've had apologies from Councillor Latty and Councillor Baines.
Thank you very much. Can I ask if members any disclosable pecuniary or other interests which would prevent them from participating in any discussion of the items or participating in any vote upon the items, or any other interests? I can take silence as there's no pecuniary interests. Admissions of the public. It is not recommended that the public be excluded from the meeting for the consideration of any items of business on this agenda. Is that right, Carol?
That is correct.
Do you think Councillor Hayden has frozen temporarily?
I'm back now. I went off, so I'm back now. Can you hear me now? Oh, that's... Okay, can you all hear me now? Lovely, right, thank you. Okay, so minutes of the West Yorkshire Joint Health Overview and Scrutiny Committee held on the 8th of August 2020. Can I take them as a true record, please? Yeah, and any matters arising? No, lovely. Oh, Councillor Rhodes.
Thank you, Chair. I have some matters arising from those minutes, and they're perhaps pertinent as we go through the meeting. If I identify them now, there's maybe a possible answer now, but subject to further discussion as we go on. And I'll identify them now from our representative from the NHS and Health Service. One is the Nightingale Hospital, the use now and future use and timescale. The second is the West Yorkshire Partnership operating through winter in terms of the winter sessions that we will be going through. The third is the flu vaccine and availability. And the fourth is the cancer situation in terms of mammograms, and that these are the routine checks. There's a report out that says there's over 1 million outstanding. So having noted those with you, Chair, can we take them as appropriate? Thank you.
Thank you very much. And yes, we thank you for raising them now, and we'll take them as appropriate during the meeting. Thank you. Okay, next item is public deputations. So Mike, can I ask you to speak on this, please?
Yes, thank you, Chair. We've had a deputation from Jenny Shepherd, and it's pretty short, so I plan to read it out if that's all right, Chair. So it's on the public record. Jenny says, with regards to the ICS work to build up capacity for COVID testing in West Yorkshire, 1. What increased capacity at NHS labs has the ICS/LRF programme created? 2. Did any increase in number of PCR machines? 3. If so, in which NHS labs? 4. I understand that Pinderfield Microbiology Lab was refused funding last year to carry out PCR testing, but was then given some money to procure a PCR machine due to COVID-19. Has this machine arrived? And if so, has it been used for Pillar 1 tests, analysis, Pillar 2, or both? 5. Also, with regard to any other increases in West Yorkshire NHS lab capacity, has this been or is this being used for Pillar 1 tests, Pillar 2, or both? 6. If no Pillar 2 tests are being analysed in West Yorkshire NHS labs, do they all go to Lighthouse Labs for analysis? If not, where else do they go? 7. There is widespread public support, 74% in a recent survey, for stopping COVID-19 test and trace contracts with private companies and handing funding and responsibility for COVID-19 test and trace to public health and the NHS, and returning to the lawful notifiable diseases processes under the 1984 Public Health Control of Disease Act. Is the ICS in favour of this? And 8, does the COVID-19 reset require any change to plans for path lab cuts and centralisation across the ICS? That's it, Councillor Hayden.
Thank you very much. They came quite late, those questions, so obviously we wouldn't expect answers to be given straight away, but those questions have been circulated, and we will. So Ian, do you want to come in on that?
Yeah, I mean, I think we can touch on those issues in the item we've got on the agenda later on, and Anthony might be able to give a brief response. But as you say, Councillor Hayden, we'll produce a full response in writing following the meeting.
That's wonderful. Thank you very much. That's excellent. Okay, so if there's no other deputations from the public, we will go on to item 6, the West Yorkshire and Cancer Alliance update and next steps to support NHS COVID-19 recovery. So this item will consider progress on the Cancer Services Programme. That is one of the priorities of West Yorkshire and Harrogate Health and Care Partnership, and will focus particularly on the impact of the pandemic on the cancer services, which we were just hearing from Councillor Rhodes, and as many of us would have heard this morning, that it's had quite an impact, a serious impact on routine screening, particular breast cancer that we heard this morning. So I'd like to welcome, we've got Caroline Coombs to talk on this item. So would you like to introduce yourself?
Sorry, Chair, Carol Ferguson.
Yeah, sorry.
Right, sorry.
It's me, it's Carol.
Oh, sorry. Oh, right, sorry. Carol Ferguson. Oh, there's too many Carols and Carolines. Sorry.
Many of us.
Yeah, sorry. Sorry, Caroline. I was putting you on the spot there.
I'm very happy if Caroline Coombs wants to take this item.
Sorry.
I'm Carol Ferguson. I'm the Programme Director for West Yorkshire and Harrogate Cancer Alliance. So pleased to come back. The paper that we circulated to you, I guess, is essentially a more formal and up-to-date version of the verbal update we gave at the last JOSC meeting. So I can run through it, the main points if you like. At the outset, it's fair to say, as you all know, and has been picked up in the media on a number of occasions, cancer services have been impacted in quite a significant way, particularly by the first wave of the COVID pandemic. We saw referrals drop considerably to around 30% of the normal levels for urgent referrals. And we saw a number of pathways for people who were already on a pathway to diagnosis and treatment paused, with their treatments prioritised and assessment of their management plans. Since sort of late June, July, that situation has turned around. We've seen referral rates rising. In fact, they've been returning to their normal rates faster in this part of the country than they have across most of England. I'm not entirely sure what the reason for that is, given that we've had a fairly steady level of COVID still in our communities, but that's very good news. And our provider colleagues treated cancer as a priority as services were able to reopen. So our treatment levels have also increased, particularly surgical treatment, which was the most effective treatment for cancer patients through the height of the pandemic. And throughout all of this, any treatments which were considered time critical and essential were going ahead throughout. But as you know, a number of pathways have paused, and therefore treatment times have extended, which is not something that that any of us, particularly our clinical teams, want to see. I say what we're seeing now is a return. As we've had a window of opportunity while routine referrals weren't quite open to catch up with a lot of our cancer activity, and the backlog of patients that had built up has been reducing steadily since through July and August. It's still higher than we would like it, but it is reducing steadily. And services have restarted, and to the point around screening, which you raised, screening services were never officially stopped, but they did pause. They restarted in earnest through July. For the three main screening programs for cancer, that's cervical, breast and bowel screening, and those services are working through their backlogs, and the Cancer Alliance has got a programme of support to that work, where we've just completed some insight work to understand what is where people aren't presenting for screening opportunities when they have them, how we can increase those. So it's really important that as those screening services begin to start again, that people do come forward and take advantage of those services. But that, again, there is a backlog that those services are working through in a priority order. Our acute providers have, over the summer, have managed to reorganise their services to establish COVID protected or COVID free sites. And we're very hopeful that that will enable us to continue our cancer treatments through what we're now seeing as a second surge in COVID activity. We're working closely with our colleagues on the Planned Care Alliance that deals with the bulk of elective care, to see how we can share that capacity as best we can. But obviously anything that is time critical would be prioritised for treatment. We're using the independent sector capacity that's available to us where that's suitable for treating cancer patients. Where it's not particularly suitable for treating cancer patients, that capacity is being used for benign work, so the NHS capacity can focus on cancer. Where we are using the independent sector, that's obviously causing some higher level of complexity in pathways, and we are picking up some feedback from patients who are trying to understand why they're being directed away from their usual provider. As far as possible, we're keeping patients treated with their usual provider for that pathway, and that's the feedback that we've had from our engagement work with our cancer patient panel. That patients would far rather stay with the teams that they know and are used to, so we're not disturbing any pathways unnecessarily in the way that some parts of the country have established centralised hubs for treatment. The decision was taken in West Yorkshire and Harrogate that that wasn't the way to go, and as far as we possibly could, we would open up capacity within each of our local providers to enable people to follow their normal pathways. Throughout all of this, we've been using our Cancer Alliance board as our key stakeholder group to monitor what we're doing, to understand how services are opening up, and to agree the priorities that the whole of the system should get behind. So where we are struggling or where we are strapped for capacity, we've got a very clear line throughout our system, both at West Yorkshire and Harrogate programme level and in each of our local places, about what is most important and where to focus our efforts. And our Alliance Board signed off a set of objectives for the next phase of work through what we call phase 3, which is the plan for the remainder of the year at its meeting in September to support what we're doing. We're now following through as a Cancer Alliance team to make sure that all the fora through West Yorkshire and Harrogate that are focused on cancer understand what the objectives are and that we're all pulling in the same direction. That was a summary of where we are. I'm happy to take any questions on anything that's mentioned in the paper or any other issues that councillors want to ask me about, and I'll do my best to answer.
Thank you very much, Carol. Yes, there will be a lot of questions, so I'll start with, and thank you for that kind of comprehensive but really kind of succinct introduction. Start with Councillor Hutchinson and then Councillor Rhodes.
Thank you, Chair. You've stated that the numbers of urgent referrals have returned to their previous levels, but obviously there was a period of several months where there were very few referrals at all. So presumably there is a backlog, even though the numbers have returned to normal. I wondered whether you'd noticed a change in the proportions coming from GPs and the proportions coming from accident emergency from the pre-COVID time, and also whether there's been a change in the spectrum of oral cancer following the closure of so much dentistry, because dental assessments pick up a large amount of oral cancer. And if those aren't happening, then there is that risk. So how will this be rectified? Are we seeing more urgent referrals coming from A&E rather than from GPs?
Anecdotally, we're seeing a rise in urgent presentation, and that is what we might expect if people haven't been presenting, as I'm sure this is where your question is going. We might expect to see more late presentations, and that they often come through an urgent emergency route rather than coming through a GP-led referral. We're doing work with our providers at the moment to understand what they're seeing, because anecdotally we're hearing from clinicians that they are seeing a greater proportion of later stage disease than in what I'll call normal times. So we're working with our providers to look at the profile of the diagnoses that they're making, so we can see where we're missing, for want of better language, missing cancers, or there are missing diagnoses that we would have expected to see. What we are seeing, to your point around oral cancers, is that whilst the 2-week wait urgent referrals have come back up, and I say in West Yorkshire and Harrogate they've returned earlier to their near normal levels than in the rest of England, which is good. We're also seeing variation within tumour types. Head and neck cancers is actually one of the cancers which we're seeing a return to. We're getting over 100% of referrals, so they're coming in some way. How they get it, we haven't got the sophisticated data to understand how they've ended up coming back in, but they are coming in as 2-week wait referrals from GPs. So it's possible that people with mouth problems are going to their GP and getting a referral that way rather than seeing their dentist. But that's surmising rather than any evidence that we're getting. But yeah, head and neck cancers is one of the tumour pathways which is returning or has returned to normal and catch up essentially, whereas other tumour pathways, lung being one of them, we're seeing a slower return to normal, and that's why we're really keen to reinstate our targeted lung health check work to go looking for those cancers in populations that are at higher risk of developing those symptoms.
Because this committee was told by Sean Duffy, Professor Duffy, that one of the reasons that this country doesn't do very well in cancer survival was because of relatively late presentation.
Yeah.
And, and once people have been diagnosed, then the results are as good as anywhere. But it's getting those presentations at an early stage. And I just wondered whether you felt that the move to onto remote consultation as a first line might pose risks for the future.
You're absolutely right. Early presentation is key to improving our outcomes, and we had an existing programme of work to try and drive earlier diagnosis and to make diagnostic tests and the inclination to use those diagnostic tests more available. A pandemic hasn't helped any of that. We're trying really hard to work with our planned care colleagues to open up as much diagnostic capacity as we can. The issue of whether remote consultations with GPs has been a disincentive to people presenting and getting referred. Again, I haven't got any evidence about that. Our engagement with our patient groups is not suggesting that, but I think it's too early to say whether that is a disincentive. And some of the work that we're trying to launch through our partnership with the Yorkshire Cancer Community, which is a third sector organisation of patient voices. We're developing something called the Cancer Smart programme, which is trying to reach into communities to raise symptom awareness through a series of, for want of a better word, community connectors. We'll hope to get some of that feedback to get that richer intelligence about what's going on, because a lot of our engagement work is with people who've already got or had cancer, rather than the general public, who are the people that we would need to reach out to answer your particular line of inquiry. But it's something I'll take away, and we'll see if we could do something to do some insight work and see if we can follow that up.
Thank you.
Thank you very much. Can I bring in Councillor Rhodes, please?
Thank you, Chair. Good morning, Carol, and welcome to the meeting. Well, I'd like to go back on a few things, Chair, if I may, that's been mentioned. First of all, the news this morning is, I'm sure, very disturbing for a lot of people in terms of the routine mammogram checks that have been put on hold, so to speak. I've listened a lot about the intentions and the plans of the Alliance. First of all, first question, do we have a figure for West Yorkshire and Harrogate of the amount of people who are waiting for the routine mammogram tests? I think it's important that the people in our region know exactly when and how, if they are affected, that it's going to be actually put on some system to get these tests available. I think that's the important part that the people we represent want to hear about. Nationally, the figures are alarming. Locally, I think we need to know if there's some reassurance in terms of the amount of people that's waiting, the amount of women, and how it's going to be addressed. That's the first question. The second question, in terms of the Alliance, I've heard about the plans from some other places in terms of using the private sector. I'd just like a little bit more information on this, because I think there was a word that said, if it's suitable. I'd like to know what that means, please, because it's interesting if we've got a backlog through our NHS providers, that if there's a way of reducing the figures across West Yorkshire and Harrogate, that's something that we need to know about. And it's all associated in terms of knowledge and information. And there was another word that I would like some explanation on about as well. And that is the word anecdotally was said twice. I had assumed, maybe wrongly, that all of the NHS streams of provision didn't work anecdotally, they actually worked on information that would be sent through GP practices, etc. And in line with the work that everybody's had to do with the COVID situation. I don't think anecdotally is something that people would understand in terms of the fear of the situation of cancer. I understand completely that in terms of emergencies and those that needed urgent care, that I think that has to be commended. But we need to know more about the Alliance, how it works, who it's working with, what the information it gets, how they disseminate that information across the patches, and how this board of members here representing the public can actually have some confidence that we are getting the true figures for our constituents across the patch. And I think it's very important, very, very important, because I have to say, my constituents, and I'm sure all of our constituents out there, don't want to know anecdotally. They want to know, is this region part of the national figures? What are the numbers? And then we can maybe cast some reassurance back to our constituents that this is being dealt with properly within the Cancer Alliance. And lastly, Chair, we were said that they were moving on to, I believe, sometimes, do forgive me, the audio is in and out a little bit. It said we're moving on to the next phase, phase 3. Can we have an explanation of what phase 3 is? And I think all of us would appreciate, in terms of the work of the Cancer Alliance, that when it comes to the issues about moving on, I'm going to be very simple in this. I'd like to know what has been a success in phase 2 before we move on to phase 3. And can we actually have some information about what that is going to entail? Thanks, Chair.
Thank you, Councillor Rhodes. James Thomas, would you like to come in?
Yeah,
and answer some of those questions, and introduce yourself, please, as well.
Yeah, sorry,
welcome.
Thank you, Councillor. I really apologise for turning up late. So I'm James Thomas. I'm the co-chair for the Clinical Forum at West Yorkshire and Harrogate, and I'm a GP. The reason I put my hand up in the chat was to respond to some of the questions that Councillor Hutchinson said, and I think there were some excellent questions, actually. I think in terms of the late presentations, and I'd come back to the anecdotal comment you mentioned, Councillor Rhodes, as well with that there. I think what would you're right in terms of presentations are presenting late. They're presenting late both within A&E departments and also in general practice there. I think the numbers, so they're not anecdotal, are something we need to look into, and each place is looking at that, because we obviously want to respond as soon as, rather than wait until we have all the numbers. So anecdotal, I accept your challenge, Councillor Rhodes, with that, and I appreciate that. But also it's important that we pick up on them, because every case is vital as important for both the individual, but also for our system and our places there. I think in terms of general practice and in terms of the system, we're very aware in terms of changing to different types of consultations and how that can affect presentation and training in that area there. And as a GP myself, one has to, it's a different type of consultation when you do that on the phone, and picking up on the nuances of people's presentations and what's right, what you think you need to see, and potentially, especially during the crisis, during the initial points of the crisis, where everyone was scared to come to public places, who do we really try and actually encourage to come down and see someone when we are worried ourselves as clinicians there. I also think that we did great communications as well early on in terms of making sure that people are aware that we're still here and still open, and to encourage people to come in there. But we are seeing, unfortunately, Councillor Hutchinson, the late presentations both in general practice and in the acutes. But as Carol has mentioned, that the referral rates and things are going back up to previous ones. But as you say, Councillor Hutchinson, that potentially there are some people who didn't come early on, and therefore where are they? and perhaps unfortunately with some of them, someone will be those late presentations. But I think in terms of general practice, I think both in terms of also in terms of secondary care, trying to do as much as we can to both encourage people to come in to present to the GPs and appropriately, and to manage them as quick as we can to make sure that we understand what their diagnosis is, because whilst quite a lot of people go through what we call the 2-week referral guidance for cancers, and whilst it's really important to diagnose that, only a small proportion do have cancer out of all those 2-week referrals. But actually, if you're that one person, then it's meaningless about the percentages of where we get a referral which is cancer there. So I think there's been communication. I think your points you bring up are absolutely relevant, both in general practice and secondary care. But I think we're trying to encourage as many people to come forward with those symptoms, the communication that Carol has talked about, and the communication we have done throughout the crisis so far.
Thank you very much. Carol, did you want to come in with some other the other points that Councillor Rhodes made?
Yeah, if I've made a note of them correctly, I'm sure you tell me if I haven't. So the issue about the number of people waiting for mammograms, the Cancer Alliance doesn't hold those figures. The screening services are run through NHS England, but I'm sure we can get hold of those from the colleagues that do run the screening services for you. The reference to what I was saying about the suitability of the independent sector provision, the issue there is that some of the independent hospitals in our part of in West Yorkshire and Harrogate haven't necessarily got the facilities to do some of the major cancer work in terms of HDU and ITU capacity or workforce or so on. So what we're doing, what I can reassure you that as a system, we're trying to maximise the use of the independent sector that's available to the whole of West Yorkshire and Harrogate. Where it is suitable for cancer work, we're putting cancer work into it if we need to. Where it isn't necessarily, and I think the Duchy in Harrogate is one of those examples where it's set up to do orthopaedic work. It's not suitable for cancer work, so that's being used more to decant benign work from the NHS, so that overall we're making the best use of all the capacity we've got available, and none of it is going to waste to get the most activity out of it. In relation to my use of the terminology phase 3 of recovery, that is simply, and I apologise for using that terminology, these are phases of planning that NHS England is using to direct the NHS as to what it should be focusing on. So phase 2 was around restoration of services, and that was the work I referred to over the summer, where services were restarted and reopened and expanded, and has enabled us to work through the backlog of cancer patients. The next phase of work is actually re-establishing more routine referrals and completely opening up the service. So that's the period through the autumn, through October to the end of the financial year. But that it's NHS planning terminology, and I apologise for using it.
Thank you. Did you want to come back, Councillor Rhodes?
Thank you very much. Yes, please.
Before I go on to Councillor Smage.
Okay. Just to come back on the questions that I've posed to Carol. I find it intriguing, to say the least, and I'll be generous, that we've got a Cancer Alliance working and they don't have any figures, or they may be able to get the figures. I think it's important that they do get the figures that I've asked for this morning, for people in our region here who may be worried of what the situation is. And I will repeat again, I think we need to know what the situation is within our localities and within our authorities. And I think that's very amazing how you go on to plan. And I'm going to speak about the plan. You're going to get NHS direction nationally in terms of the plan phase. I appreciate that. Now, is it possible, Carol, that that phase 3 is sent through the chair and officers so we can all see what the direction that's going to be for the future. I think that would be very informative for us all. And then lastly, Chair, I'm going to go back to our GP colleague that came into the meeting. Welcome to the meeting, good to hear from you. I do know that the NHS nationally has actually given some direction to the GP practices to encourage people where possible to come back and have face-to-face appointments. I've yet to see that that's on the increase in my locality. I don't know in other authorities, but that's a directive that's come out. And in view, obviously, of the rising figures on COVID now, it's possible that more precautions will have to be taken. But I think from all of us here this morning, Chair, what we've heard from the Alliance and from our GP colleague, it's important that the message goes out. This is the position within the West Yorkshire and Harrogate region. These are the plans that's in place, simple points that people everything, not long statements. I appreciate that this is how it's got to be done, but we need those figures. And I would dearly encourage, Chair, that from this morning's meeting, we can actually get those figures and put out the figures, but as well as that, to let people know that action's being taken, what the action is, and how much of a priority it's also for people to contact their GPs in case they are long overdue routine appointment. Thanks, Chair.
Thank you very much. Did you want to start, Carol? It is really important to get that message out. I had a meeting in my Leeds capacity with our local medical council at LMC, and I know that doctors, GPs are very frustrated because they are open, but it's getting that message out, and they've never closed. But it's, from what I was told, if you are clinical, if it's a clinical need to see you. So yeah, if you wanted to come back there, James, and then we can go to Carol too about the figures. And it is important to get those messages out for people to go.
It really is, Councillor Hayden. And I think we've clocked that right at the start of this, when we initially started to see that reduction and people being worried and coming in. And at the same time, knowing that general practice is having to change how it works in terms of telephone consultations, e-consultations, video is that sort of thing there, which has been miraculous in some ways, because people have felt confident then still being able to access their GP at times when they didn't want to come down. At the same time, kind of balancing that off with kind of seeing people face to face. So GPs, you're right to say, GPs have never said no to people coming down, but it's a mixture of things. The access for patients has widened actually dramatically in terms of the opportunities for people to access their general practice through e-consults and telephones, which in my practice and seeing other practices around me has really kind of, the numbers have increased dramatically there. Yes, the face-to-face have not come back to what they were before, but then sometimes actually they weren't needed. The important thing here is we need to make sure that where we as a clinician feel that we need to see someone, that people feel safe when they come to the practice, and so they feel they can come down and be seen, and also that patients can access their GP to see people face to face as well, and they have. And it's about encouraging that and getting the message out, as you said, Councillor Hayden. So I'm absolutely supportive of that. But I'd like to just say that I think those other ways of accessing general practice have also been miraculous in terms of enabling some ways of communicating and seeing things very quickly, wherein perhaps in the past they may have taken 3, 4, 5, 6 weeks to see their GP face to face, have been able to do it within the 24 hours sometimes. So there is a balance, but we actually need to get it right. Thank you.
Yes, because I've accessed a GP twice in the last 6 months, and it was it was brilliant, because I got to speak to a GP that day, and and things were sorted out really quickly for me. But we also have to remember that not everyone is comfortable using technology or and want to see their GP face to face, even if it's not clinically needed. It's that desire that certain sections of the population may not be as happy to just do it digitally or on the phone.
Agree.
Yeah,
absolutely agree.
Yeah. Carol, would you like to come in on the other points that Councillor Rhodes made? Thank you.
I think in relation to the availability of the plan, I think that would probably be picked up in the next agenda item that Anthony and Ian will be talking about, because obviously we don't plan for cancer in isolation from the rest of the service. So the cancer activity is all part of the overall partnership plan. So I think Ian or Anthony will pick that up.
In terms of the data, are we able to see, are you able to get hold of the figures for our region so we know what's been missed, or, you know, for want of a better play, you know, in our communities?
In terms of the breast screening data, I will ask the NHS England folk. They actually sit in Anthony Keeley's team, so we can take that away and see if we can get that for you, because it runs slightly separately from the Alliance business, and I realise that doesn't sound that sounds a bit strange, but that's why we haven't got the data in the Alliance.
Okay, thank you. Can I bring in Councillor Smage, please? And thank you for waiting.
Thank you. You're welcome. I had a slight technical blip, but never mind.
It's happening a lot this morning.
Yes, it is. Yeah. Right. I've got 3 questions actually. At point 7 on your paper, you talk about endoscopy services and there being a wait for endoscopy services and cases being risk assessed and triaging tests, and looking at other clinical innovations which could help depending on service development funding. I wonder if you could expand on that, because if there are problems with the waiting list for endoscopy, then that impacts on other services as well. So I think we'd like to understand about that, please. From the Alliance board, you say at point 10 that there's a brief set of system-wide objectives for all statutory partner organisations for recovery, and you're trying to ensure clarity of purpose is communicated and understood. Does that indicate that purpose and it was not understood previously, and what are the brief set of system-wide objectives? And then you also ask about how any support members of this committee can give to encourage people to seek help and advice, and I was wondering if you were proposing any ways in which we could do that. Thank you.
Thanks. Thank you, Councillor Smage. Yeah, so your first point around endoscopy services, endoscopy services were particularly badly affected by the pandemic because of the it's what's called an aerosol generating procedure, which was considered particularly risky. And so a lot of, well, all endoscopy, to all intents and purposes, other than endoscopies that were considered absolutely urgent and essential to be done, were paused. And that has obviously affected people, particularly on colorectal pathways, and also upper gastrointestinal pathways. And they make up the patients waiting for endoscopy have made up the majority of the backlog of patients that's been waiting. So it was really important that as those services reopened, that we were able to, the clinical teams were able to restart their endoscopy services, bringing that waiting list down in line with clinical priority. So there are some tests that can be done which can risk assess patients to see whether they're particularly at higher risk of having something serious wrong with them, or whether they're at relatively low risk. One of those tests is called a FIT test, which looks for blood in poo, basically. And so all patients who were waiting on an endoscopy list in West Yorkshire and Harrogate have had that FIT test to understand their level of risk, and therefore as the waiting list moves, we can bring people through in a priority order based on the level of concern. We're also introducing some other risk assessment or triaging tests or substitutions for endoscopy. There is already a radiological examination which can be used in place of an endoscopy for some patients. We're also introducing some diagnostic tests and procedures that have come out of research. Something called cytosponge, which is like it's like a little sponge on a rope that the patient swallows, and then that brings out some cells when the string is brought back out of the patient. So we're participating in a research trial to use that on some patients who are suitable. We're also looking at funding what's called colon capsule endoscopy, where a patient can, rather than have an endoscopy in a traditional way, swallows a capsule that's got a camera in it and that's tracked through the gut. And that again is something that could be done that isn't aerosol generating, and will enable us to reduce those backlogs of patients faster than otherwise would have been the case. So we're putting as much of our service transformation money as we can into those innovations to reduce those backlogs. In terms of the objective setting, I didn't mean to infer that people were not clear what they should be doing, but it is particularly important when resources are stretched and the workforce is stretched, that where we put our efforts is all aligned. And that was the thinking behind having a very clear set of objectives, which are in line with what's in the paper, around understanding where the unmet need for cancer treatment is, and looking for where particular populations might have been particularly adversely affected by the pandemic, and managing the immediate growth and restoration of diagnostic and treatment services, and reducing the number of long waiters. So the objectives are in correspondence, which is in the public domain on the Cancer Alliance website, but again, happy to share those objectives with members of the panel in writing if that's helpful. The final point around seeking help and advice, I think the biggest risks to our cancer services over the next few months, particularly as we're seeing a second surge in the pandemic, is maintaining our workforce that's available. I think the estate's set up to enable us to maintain our treatment, but if the workforce is not available to us because it's isolating or unwell, that will be a big risk. But the other big risk is that we can't treat patients who haven't presented to us. So we're putting effort within the Alliance team into campaigns and reaching into communities to encourage people to present if they've got symptoms that are worrying them, and to take up screening appointments and so on. But any of our partners in our system who have got reach into communities to encourage people that services are safe to engage with, and that they should come forward and speak to their GP or take up screening tests, is helpful. So if any of the members of the committee can use their contacts, their reach into communities to reinforce those points, that would be really helpful to us, I think, because we need to take every opportunity to make sure that people don't sit at home thinking that they can't approach their GP if they're worried about something, and to be aware of what they should be worried about.
Okay, thank you. Can I come back on the endoscopy and the different ways that you're trying to provide a service? It says in the paper that it's subject to the reintroduction of service development funding. Is that funding in place then?
Since we wrote the paper, the National Cancer Programme have given us an indicative allocation for the remainder of the year, yes. So we're looking at how we can get the most out of that to support these objectives, yes.
Thank you.
Thank you, Councillor Smage, and thank you, Carol. Councillor Hutchinson, your hand went up. Did you want to say? But then it went back down. So.
Yeah, that's because Councillor Smage asked exactly the question I wanted to ask.
Oh, brilliant. Like teamwork, excellent. Is there any other questions? Councillor Greenwood, did you want to say anything? Or
yeah, it was just mainly about the mammograms, really, just to let you know that I'm one of those million people, or however many there are, that should have had a regular mammogram in May. I've not heard anything, which worries me slightly, even if they tell me that the appointment's going to be 3 or 4 months down the line, but I've literally not heard anything. So nobody's even got in touch with me. And they've obviously got records of people that are now falling behind. So I think just to reassure everyone, I think it'd be nice if we could just send a letter out to these people to say, you know, you've not been forgotten. We have got a backlog, and we'll be sending your appointment as soon as it's arranged, something like that. Because at the moment, I don't know what's happening.
Thank you, Councillor Greenwood. I will feed that back, and it's you know, to the point that James made earlier. Some of these figures are really huge, and we bandied them about, but actually, each of those numbers is a person, and we need to remember that at all times, because there are some frightening numbers going around. But I will certainly take the point about making sure that people are aware they haven't been forgotten. As well as getting hold of the numbers for you. Thank you.
Thank you.
Thank you. And before I bring in Mike, I'd just like to ask Carol a question. You mentioned priority order in terms of the screening coming back. So is there what is that priority kind of order? And you know, are certain people who have been not seen in March to June, are you tackling certain people first, or just on when they should have been seen? Or
my understanding of the way the screening services were reintroducing was that they were trying to get the people who were already somewhere in the system started as a priority, but that was at the very reset of work back in July, which feels like a long time ago now.
Yeah.
So for people who were routinely on a list and would have been recalled, I can't say for definite, but I would assume they're being called through in order of, in chronological order, if you like. But again, I can follow that up with the people who run the screening services and get some clarity for you.
Thank you. Thanks very much. Mike, did you want to come in?
I just wanted to say that I understand Dr. Thomas needs to leave at 11.
Oh, right.
No, I thought it was last week, so it's fine this week. Thank you. I'm here for the duration.
Okay.
I won't turn up late and then go early. I'm sorry.
Right. So, okay. Thank you very much. Is there any other questions on this item? No, that was really, really informative, really quite comprehensive answers. So thank you very much. And it's great to hear from both the Alliance, but also from, you know, practicing GP and that kind of real experience and in real time and as well. So thank you. So, but as you said, Carol, it does feed into the next item in terms of planning for what's happening ahead. So we'll move on to the coronavirus pandemic. It's a word I never thought I'd be saying, and I've said it a lot this year. Pandemic. So update from the West Yorkshire and Harrogate Health and Care Partnership. So I'm not sure who wants to speak on this first, and I got it wrong last time anyway. So Ian, do you want to come and speak?
Yeah, I'll make a start if that's okay. And
thank you.
James has introduced himself, but also we've got Rachel Loftus on the call, who's the head of Regional Health Partnerships, and I think Anthony Keeley's been struggling, but he's there now. Are you all right, Anthony?
Can you hear me?
Yes, we can hear you and see you, which
Great.
is excellent.
Apology, I seem to be having strange connection issues, but fingers crossed that'll stay.
It's something. It must be the weather or something, because I've never had a glitch before, and I had a glitch earlier. So yeah, good to see you. Thank you.
Thank you. Thanks, Chair.
Okay, thanks, Anthony. So you've got the paper, and I'm conscious that there's quite a lot of content in the paper, so I'll not go through it in a huge amount of detail. I guess the first section just reminds us of our context. So as an ICS, we're a partnership. We sit outside of the formal command and control arrangements that have been put in place through the LRF, local resilience forums, and the NHS command and control structure. So we're not part of those arrangements, but what we're clear about is that working together on the issues that we face in the pandemic is really important, and the partnership ways of working we think can really add value in that respect. We've got our 3 tests for whether we work together. So is there an opportunity to work together at scale to achieve critical mass on some of these issues? Can we use the partnership to share some of the good practice that we've seen in response to the pandemic? And are there any really complex or wicked issues that we'd want to work on together as an ICS? As I said previously, we produced our 5-year strategy in December 2019, 3 months before the pandemic. I guess those priorities in that document are still important to us, and the way of working that we describe in that document are still important to us, but we recognise that the context that we're working in is completely different. In terms of the current position with regards to the sort of the spread of infection, you know, what's clear is that we're in quite a different situation now to the one we were in when we met last time in August. So back in August, we were in a position where there was a relatively low and fairly stable level of infections. And what we've seen since then, particularly in the last 3 or 4 weeks, is that rate of infection started increasing pretty dramatically. The paper says that it's estimated that it's doubling every 7 or 8 days. It might be slightly more than that now, but we're still seeing that exponential growth in infection rates right across the country. As you know, West Yorkshire, probably in the last 3 or 4 years, has impacted more than most areas. We tend to have higher rates of infections than many other parts of the country. You'll be aware that Bradford, Calderdale, Kirklees has been in and out of localised restrictions over the summer. You'll also be aware that Leeds now has localised restrictions, and Wakefield's been on and off the sort of the national watch list, as they call it. And so that's the sort of the context that we're working in, and you know, it is quite a precarious time in terms of those infection rates. Carol mentioned the 4 phases of the COVID response, and Carol's absolutely right. These are kind of planning horizons. So we're in phase 3 now in that table on paragraph 13. And this is basically, it's probably the most complex phase we've been in, where we're trying to back essential services, routine services, while dealing with further outbreaks and secondary spikes of COVID infection, and while preparing for a winter where we know the pressure on services is greater than it is at other times of the year. So that's the sort of the context, and it's a complex period, and it's quite a challenging period in terms of managing those competing demands on services. We've got 6 overarching priorities as an ICS in this phase 3. And we've set those out in paragraph 15, and the rest of the paper really describes in a bit more detail some of the work that's happening to each of those areas. So the first priority is around providing essential services for people who have COVID-19. And you know, at the minute, fortunately, the number of people in hospitals with COVID-19 is significantly lower than it was at 2020. We have seen those numbers increasing fairly steadily, it's fair to say, over the last 3 or 4 weeks. We're expecting those numbers to continue to go upwards as the rate of infections go upwards. I think the question was raised about the Nightingale facility. That will remain available until the end of March 2021, should it be needed. Our hope is that that facility won't be needed, and we can manage critical care demand through the existing NHS facilities that we have. But you know, we're planning for the worst, I suppose, and hoping for the best in terms of that facility. It has been used, as we've covered in the paper, to deliver outpatient radiology services, and over 1,500 patients have been scanned. It's worth saying that that's a Yorks and Humber facility, so the way that capacity will be managed will be done across the 3 ICSs, ourselves, Humber Coast and Vale, and South Yorkshire and Bassetlaw. Raised the issue, PPE and testing. So PPE was a significant issue at the start of the pandemic. We're in a reasonably good position on PPE now, where we've worked together to identify new sources of supply, and we've got a reasonable supply for the next month or so, and that PPE group we've established will be in place to March 2021 to oversee that supply chain of PPE. Jenny Shepherd asked a range of questions about testing, which we'll provide a written response to. I guess just to say that the testing capacity is increasing and has been increasing throughout the sort of the period of the pandemic. I think it's about 3,500 tests a day that can be provided across the region, and there are plans for that to increase. We're absolutely aware of the significant pressure on testing at this point in time. That's a combination of increased demand for testing as the numbers go up, and also sort of limits on the lab capacity to process those tests quickly and well. That's already having a knock-on impact on staff providing frontline services, and we've got more staff now who are self-isolating or staying at home because they may have COVID, but the test results haven't come through yet. So that first phase, or that first priority around managing COVID demand and the work that we're doing there is still really important, and will be increasingly important throughout the next few months as we expect those rates to continue as we've seen them. The second priority is around how we work together to provide other essential services during this phase. Carol's spoken a lot about cancer services. We're having the same conversations around other planned procedures, primary and community care, and James has talked a little bit about some of the challenges around that. Mental health services, we're expecting a surge in mental health demand to hit us later in the year as the impact of isolation and some of the economic downturn effects start to translate. There's a big focus on flu at this point. We're really concerned that a second spike in COVID will coincide with the sort of a spike in flu, and both of those things will hit people and services through winter. We've established a West Yorkshire and Harrogate arrangement that's chaired by Owen Williams, who's the Chief Exec at CHFT, and Carol McKenna from Calderdale from Kirkley CCGs to chair a West Yorkshire flu forum that will share good practice at place level and identify common barriers to providing vaccinations. That board is to support the local arrangements being put in place on flu, and those local arrangements are kind of really important. The third priority is supporting people who are shielding. Obviously the rules changed on shielding. It was paused on the 1st of August. Local authorities are continuing to support people who are vulnerable during this time, and we may well need to have further iterations of shielding depending on how things happen nationally and also in relation to local restrictions. And Rachel's been heavily involved in that work. The fourth priority is around how we support health and care staff during what has been an extremely challenging and stressful time for those staff. Again, we describe in that section some of the work that's happening there. The review being led by Professor Dim Donna-Kinnair is progressing really well. It meets for the final time, the review panel meets for the final time October the 14th. We are launching, or the review panel is launching that report on the 22nd of October. And then in response to that, we'll be producing an action plan as an ICS, which will be considered through the partnership board around how we're responding to those findings, particularly about how we support Black, Asian, minority ethnic staff and communities. The fifth priority is trying to understand the wider impact of COVID and the wider lockdown on different communities. So this is the direct impact of COVID, as well as the indirect impacts of lockdown, of isolation, of the economic impacts of lockdown on different population groups. And again, we describe some of the work that we're doing there. To note in paragraphs 47 that Owen Williams from CHFT has led a national piece of work around understanding some of those impacts. There's 8 actions coming out of that we've listed, and again we're picking those actions up through our improving population health programme. And the final priority is this kind of planning piece that Carol alluded to in her presentation, how we plan what we're calling stabilisation and reset planning for the rest of this financial year. You know, the goal is to accelerate and return activity for non-COVID services to as close as we can to normal levels, recognising that we want to build in some of the innovation that we've seen, how we prepare for winter demand pressures in that context, and local and possibly national COVID spikes, and how we take into account the lessons that we've learned and the beneficial changes. That we've actually linked the guidance there, so you can actually see the guidance from NHS England and the requirements from NHS England on that. We can share that as a PDF to the members of the panel if that would be helpful too. We're right in the middle of that process, it's fair to say. When we started the process, as you can imagine, the infection rates were a lot lower, and some of those plans were predicated on a scenario where the infections rates were lower than what we're seeing. We're now in the process of adjusting those plans to reflect that we're likely to see a second spike in infections later in the year. And that work is progressing, but we'll be able to share some of that with you at a later date. Conscious that that was a bit of a whistle-stop tour through the paper, awful lot going on, but I think we can open that up to questions now, if that's helpful, Councillor Hayden.
Thank you very much, and thank you for that, and for the paper as well. And I'll open it up to questions. So I'm going to start with Councillor Greenwood, and then Councillor Smage, Councillor Hutchinson. Did I just see your hand go up there, Councillor Clark? Yeah, and then Councillor Clark, and then if anybody, I'll pick up anybody else as and when. Councillor Greenwood, please.
Thank you. Just a couple of, I've got one question, but first of all, I just want to mention about the flu jabs. My mother-in-law is 92 years old. She lives in Guiseley, which is in the Leeds area, and she's been told that there's no more flu jabs available for her. Now, I'm pretty worried about that. As you can imagine, she's just been in hospital. She's broken a hip or pelvis. So she's not in a good place anyway. And she's having physiotherapy to help her to walk again. So the last thing she wants to be is knocked out by flu. So that's just one thing that concerns me, because me and my husband, we're not at the I think it's 64-year-old age yet, but they are offering them to over 50s now, aren't they? But we've booked ours in at Boots, the chemist. Now, I don't know whether we're going to have to pay for it or not. I've no idea. It doesn't really matter. We'll pay for it because I think we need it anyway to help the NHS out in case there's a flu pandemic. But I'd hate to think that we were taking up flu injections when people like my mother-in-law desperately needs it, because like I say, the last thing she needs is to get flu. So that's just one thing. But then I've got more of a question really here. It's just about the BAME communities, in particular the Asian communities. Now, there's never really been any evidence, proper evidence, that suggests that Asian people are more susceptible to catching it. I do know that the numbers are quite high within Asian areas, which sometimes sets off some not so pleasant conspiracy theories that Asian people are spreading it around. Now, I think it's because, like, if my family got it, there'd be 2 people that catch it. If an Asian household catches it, there could be up to 8 people. So those numbers are skewed already. So I just would like to know, A, if we've got evidence that Asian people are more susceptible to catching it, and if so, what is it? And if not, then those numbers are a little bit unfair, because a lot of the Asian communities are getting blamed for spreading this virus around, which I think is grossly unfair. So those are my 2 points, really.
Really good points. I think on flu jabs, I think what we've seen is a much higher demand for those jabs from groups that are eligible to receive them, and I think that is a positive, because we want as many people as possible who are eligible to be, to have that vaccination. I think what that has meant is that it's put pressure on supply, as you say, And part of the focus of the West Yorkshire Flu Board that I mentioned, that's absolutely on their radar in terms of working with NHS England around addressing those issues. On the question around Asian populations and whether they're more susceptible to infection, I've not seen evidence that they are. I don't know whether James might want to come in. I'd say two things. Firstly, I think the point around housing and families that you raise is an important one. I think the other thing is that the jobs that people sometimes do from those communities makes it harder for them to work at home and protect themselves in a way that it does for the communities. And that applies to Asian communities, but I think it also applies to more deprived communities generally, where there's those jobs that require people to go out and meet people on a day-to-day basis. I guess the challenge for all of us is to make sure that we challenge those messages when we hear them, and we've done quite a lot of that in the partnership, and I also know that leaders across the system have done, because as you say, there's a lot of nonsense that has been going around people who are causing those spikes, and I think we've all got a job there to try and knock those things on the head when we hear them. James, I don't know if there's anything that you want to add.
Yeah, I suppose on the first thing about the flu vaccines, yes, there is demand is increased for obvious reasons there. There are different types of vaccines as well in terms of age groups, as well in terms of younger people having different type of vaccines. So we can get on doing vaccines for younger people, even though the older people may not be having it, because we might have their vaccine in at the moment there. But absolutely right, Councillor Greenwood, there are some issues and challenges with the supply, because the increase is so great this year for the obvious reasons, which is a positive. But I understand the issues you're saying, especially with your mother there. I think in terms of the second point, in terms of with BAME and the populations there, I think Ian, you've covered it really there. I think the jury is out in terms of, are there specific reasons, query genetics and other elements in terms of stress on that group as well, in terms of their susceptibility there. But the other reasons, the wider determinants, the housing, the jobs, the situations that they may find themselves in, put them at greater risk as well there. So it's multifactorial, I think, rather than just being one thing.
Thank you. Rachel Loftus, would you like to come in? Thank you, Rachel. Oh, I'm struggling to hear Rachel.
It's not just you, Councillor Hayden. I don't think any of us.
All right. Yeah. Have we got? Okay. Oh, she's going to write it there. Okay. Thank you, Rachel. It might be a volume on your computer. Okay, so I'll move on to, and we'll get Councillor Smage. Are you okay there, Councillor Greenwood? With the, yeah. I'll move on to Councillor Smage, please, with your questions.
Thank you.
Thank you. You mentioned the urgent and emergency care programme embedding the talk before you walk model of access. And I wonder if you could expand on that a little bit, please. And a national rollout in December 2020. And also the winter pressures. Have you a plan on a West Yorkshire level as well as on the local footprints as well? And are those plans working together? Have you been working together on those plans? And for my third point, I perhaps ought to say that I live in a household with somebody on the shielding list before I ask the question. But you're saying that you're looking at any future support offer in collaboration with people from Shielding Group, and I think that is a good idea, that people should be able to say their lived experience of what has happened previously, and I just wondered how that was working in practice. Thank you.
Thanks, Councillor Smage. Rachel, you might need to do some more typing on the shielding question.
I was only halfway through typing the other one. Is that better?
Do you want to pick that one up first, now that we can hear you?
Yeah, we can hear you. Brilliant.
Yeah, so so just across West Yorkshire, obviously every local authority, every local place has a different shielding team arrangement around it, but all of us collaborate together on a West Yorkshire level as well to share best practice. So the University of Huddersfield has just done a really, really good piece of work around hearing from people in the shielding group. And we will be sharing that out as a best practice seminar for colleagues across West Yorkshire in the next couple of weeks. As soon as that's published, that was about, I think, 800 people from the shielding group contributed to that in some way, shape or form. All of the health watches have done various different ones, and again we're up to quite a significant number of people who've filled in surveys or participated and attended. All of them, or the communities of interest forums, as all particularly for people who are hearing impaired, sight impaired, who found it very difficult to access the national system. So all of that is going into the planning for an assumed shielding phase 2 that will have to come in if rates continue as they are, and we don't know if that's days away or weeks away or months away, but the planning is going in place there to basically make sure that we don't make some of the mistakes that were made at the very beginning. We know a lot more now than we did. So for example, the advice given first off for shielding was stay at home, close your windows, don't go out. And we know that that's actually had a significant impact on people's physical and mental well-being. We're seeing increase of frailty and other things. So the advice itself will be much more nuanced and targeted to people about staying safe, making the right decisions for them, making sure that carers in the shielding group and people who are cared for in the shielding group have got the right support arrangements and bubble arrangements and things like that in place. So all of that is kind of happening at the moment through direct kind of commentary from people in the shielding group.
Thanks, Rachel. And Anthony, I don't know whether you want to pick up the planning and talk before you walk stuff, or whether you want me to do that one.
Yes, I can come in on that. And just to introduce myself, Chair, I'm Anthony Keeley. I work for NHS England and NHS Improvement. I'm the locality director for West Yorkshire and Harrogate. So, yeah, talk before you walk is another bit of jargon, and apologies that we've used that. It's actually referring to a new national programme which will be called NHS 111 First, and this is to encourage people to use NHS 111 to access urgent care services rather than going to A&E departments, for example, in the first instance. And that's really about making sure that people get directed to the most appropriate service for their particular condition and needs. And this will be, apart from anything else, this will be an important way of making sure we don't have overcrowded A&E departments, which would be to no one's advantage, with the spread of the virus. So the NHS 111 First programme is being rolled out over the coming months, and we think that'll have a very positive effect in terms of making sure people are able to access the right services for them, and that will be a key element of our overall winter plan. So just picking up Councillor Major's question. So as an ICS, we are looking at, or we are not more than looking at, we are now developing what we call a winter delivery agreement, which is essentially a plan built up from A&E delivery boards and local partnerships in each of our places to a whole West Yorkshire and Harrogate-wide plan for how we will manage winter pressures this year. And of course, that will need to take into account the multiple impacts of normal winter, the current increase in COVID pressures we're seeing, which may develop into a significant further pressure on demand for hospital services, as well as all of the wider kind of arrangements that need to be in place around social care and the flu vaccination programme, for example. So there's a detailed planning process underway around that winter delivery agreement, which will come together over the coming month or so. So I'll pause there, Chair, if that's okay, but happy to come back on any of that if necessary.
Thank you. Councillor Smage, did you want to come back on?
Yeah, I just the time in about a month. Let's hope that winter will wait. Because I understand that it's that it's complex,
Sure.
but yes, okay. The health inequalities that's mentioned in the paper as well. You're saying that you've got 8 themes, and I'm just wondering about whether the health inequalities, how you're looking at health inequalities. Just briefly, please. Are you looking place up or West Yorkshire down for health inequalities? Thank you.
So the 8 themes come from the national work that Owen Williams led. I think the answer in terms of how we look at health inequalities, it's probably neither place up or West Yorkshire down. It's probably communities up. But James, did you put your hand up? Do you want to come in on that?
Yeah, no, I think I was just about to say that. I think it's a bit of both. It's where, as going back to Ian's, the 3 functions of the partnership is where we can add value. So I think where we can do that across West Yorkshire and highlight things and share good practice with communities, then there's some examples, and that's some of the examples we've picked up on recently is about working with the voluntary sector and how they interlink with health. And hopefully what we'll get is some great evidence and of what works and how we can then share that across our partnerships. But at the same time, all of this is happening within our communities. So it is about what's happening in place and further down within the communities there and learning from there. So I think it's both. It's being smart in terms of where we can add value as a whole system. And that's about how we can share and what we need to do kind of once. And what some of the kind of big dilemmas that we might be able to all as a system try and tackle there. So it's a mixture of things, but absolutely at the heart of it has to be the communities. It can't be about the system.
And just to add on that, we've published the papers that were the evidence for the review chaired by Professor Dame Donna Kinnair, and there's an awful lot of really sort of good quality information there about some of those inequalities and how they play out across different communities. So that they're on our website, but what I can do is I can ping those to Mike so he can send you them directly if that would be helpful. Just seen in the chat that you're proposing to have a more detailed conversation on health inequalities in November. I think we'd welcome that because we'll actually have published the review and we'll be starting to formulate our response to it as an ICS. So the timing on that would work pretty well, I think, from our perspective.
I think it would be good if we could have that link. That would be really good in anticipation of November. Thank you.
Definitely.
Thank you very much. Can I bring in Councillor Hutchinson, then Councillor Clark, please?
Thank you, Chair. One of my questions is about how the private hospital chains are involved in the NHS response to the reset of services. My understanding is that there's a centrally negotiated contract until the end of the financial year to allow the NHS access to the space, operating theatres and diagnostic capacity in private hospitals, because, you know, although medical staff are the same across private and NHS hospitals, we're suffering from a severe shortage of space in the NHS estate in the time of COVID. So who decides what use is made of these facilities? If the local trust has priorities, say they're wanting to deal with a backlog of joint replacement operations, obviously there will be people with private health insurance, self-paying patients who also want those sort of operations done as part of the normal working of those private hospitals. So who takes priority? How is that actually worked out? And is there any additional reimbursement on top of the contract? Is the cost borne centrally, and how much falls on local trust budgets? I'd also like to know about the way in which the Nightingale Hospital in Harrogate is actually going to function if we get increasing numbers of seriously ill COVID patients. The Chinese used their shelter hospitals to care for relatively mild mildly ill patients, taking them out of the family setting so they were less at risk of spreading it throughout their families. But my reading from the report is that the Nightingale Hospital would deal with people who needed critical care. But am I correct there? Because people who need critical care often go on to require support for renal failure, cardiac failure. And is that the right kind of setting? Should we be having the less seriously ill patients in the Nightingale Hospital and use the full functions of general hospitals to support the more seriously ill? Where will the staff come from for the Nightingale hospitals? Because most of them will presumably be NHS staff who've got who we need in the main hospitals. And how are the costs apportioned between central contracts and the local health system? So sorry, there's a number of parts to those questions, but I would like to know more of the detail and of the strategy for the Nightingale hospitals.
Can I just suggest that that if people can take Councillor Hutchinson's first question, and then I'll bring in Councillor Clark, because he will have questions about the Nightingale Hospital and have and address both those questions after the Councillor Hutchinson's first questions have been answered. Does that make sense?
It makes perfect sense. There's a level of detail there that we might not be able to give full answers to at this point, Councillor Hutchinson, but we'll obviously provide further information after this if needs be. Anthony, I don't know whether you want to pick up the point.
Yes, I'll start on the independent sector arrangements. Ian, thanks. So Councillor Hutchinson's right. There is a national contract which was agreed between NHS England and the sort of independent healthcare sector providers early on in the pandemic to make their facilities available to the NHS to support our response to the pandemic. And that's actually been a really important feature of making sure that we do have adequate capacity, adequate space and facilities to get normal services back up and running over recent weeks and months. So the way it works is it's a national contract. It's nationally funded, and it doesn't actually run through to the end of the financial year. It's currently planned to run through to the end of November, and the expectation is that after that it'll be replaced by, if you like, local negotiations between IS providers and the NHS locally. We'll see how that plays out, but that's the current position on the contract. So the way it actually works in broad terms is that the independent sector hospitals are kind of paired with their local NHS trusts and effectively operate as part of an expanded trust capacity. So, and it's the trusts and the partners locally in each place who decide which what type of services they want to have provided in those facilities, and the mix, the appropriate mix of services. And that obviously responds to the different circumstances we have in our different hospitals in terms of their need for space and distancing and infection control measures. All of that influences, what's the appropriate sort of strategy for having particular services delivered in independent sector hospitals. And Carol Ferguson talked, for example, earlier on in this meeting about the extent to which cancer services can be provided in those facilities, and that's not always appropriate. So the IS providers are also within the terms of the contract able to continue to provide services to their private clients, but the NHS has a particular amount of capacity that we're paying for that takes priority under the contract. So, if the NHS has taken up all of the capacity we're paying for and want to use, the private providers can use any additional spare capacity they have to continue to provide services to their paying customers in that sense. So I hope that gives a broad overview of how the the independent sector arrangements are working.
And can I just ask if the tab for that is picked up as part of the trust's budget, or whether that contract was funded centrally?
Yeah, it's funded centrally, Councillor. So it's part of the additional COVID-related costs, as we would call them, that the NHS is bearing. So that's a nationally funded arrangement.
But from the end of November, that is likely to change, and it will then become the part of the trust's financial liabilities.
That's right. So the financial. We've only recently received details of the sort of the NHS financing arrangements for the second half of the year, and the financial resources available to NHS organisations locally are kind of calculated to include the need for any local commissioning of independent sector services in the final quarter of the year. So that'll all be subject to local planning and decision making after that.
Yeah, thank you.
Thank you very much. Councillor Clark, can I bring you in, please, to about the Nightingale Hospital? Or I'm assuming that's what your questions will be around.
Yes. Yeah, thank you very much. My camera's gone off. I don't know why. You can hear me, can you?
We can hear you.
Yeah.
Oh, we can see you as well now.
Okay, fine. No, I mean, sir, as you know, and the fact that you and I sent the letter to NHS to keep open the Nightingale Hospital when it was under threat, that worked very well. And I'm very pleased that we've had an assurance today that it will be kept on at least to the 31st of March, because there are a number of people, mainly business people in Harrogate, who would rather have the Nightingale Hospital put back to being part of the conference centre. But I think it's a facility that hasn't been used very much. There was some work done there, but there was nothing on the virus. And I don't know if Ian can give some information, or Anthony, on what the plans are. And as Councillor Hutchison asked earlier, that this is a tremendous facility that is lying empty at the moment. And I know work has been done on the other acute hospitals across West Yorkshire and Harrogate to gear them up for difficult cases with the virus. But it seems to me that this facility could be used for any sort of work that wasn't of particularly intensive and acute, and that it could be used for flu vaccinations or all sorts of things. I think one of the problems is that Harrogate is now in Humber Coast and Vale rather than in West Yorkshire in Harrogate. But as we said earlier, Ian said earlier, the three ICSs, including Sheffield, can come together. And I just wondered if there was some way we could use the facility in Harrogate to be used for that.
I think James would like to come in on that from a clinical perspective. James,
sorry, before that happens, I think some people haven't got the mute on and there's telephone calls or something. Lovely. Yeah, James, did you want to?
Yeah, so I think that great comments from both Councillor Hutchinson and Councillor Clark there in terms of the Nightingale Hospital is a massive success in terms of how quickly it was set up for our populations, and it was always hoped that in one sense never to be used to its greater extent. And I think we have to kind of, the fact that the places and the trust, the acute trust, managed the first phase, really not having to use is quite amazing, really, in terms of their capacity and what they dealt with, and how they increased their capacity within their hospital in terms of the initial phases there. So in a way, it's a success that it's never been used. But I actually take your point, Councillor Clark, in terms of the possibility for its use. And I think since the initial surge in the crisis, it has been used for other things apart from dealing with COVID. So some of the diagnostic work that I think in terms of the imaging has taken place there as well. So to try and help with the backlog that we were talking about earlier with diagnostics and cancer diagnosis there. So it has been used in that way. Your comment, Councillor Hutchinson, about what type of people could go there, very astute in terms of picking up on that, because I think you're right. Initially, it was felt that all the ITU patients would go there, and that's what it's all set up for there. But you're right, there are some patients, and we've seen that with COVID in the phases where multi-organ failure and the complexity is such that actually possibly that may not be the best place for them to be out there. So therefore, are there other options for patients who have less severe implications from COVID could be managed there? And I think that would be something that I think they'd be looking at as well. So we're learning from the first phase of COVID about how we implement for any next surges there. And then the other thing about the staffing is, whilst I think there is kind of bringing people back into the NHS and involving those where we can, who are appropriately trained, who weren't affiliated to other organisations. And I think all places and all three ICSs try to man the place, but it's also needed to be manned, staffed by the trusts, and therefore you're right to say that then takes away staff from those trusts, and in a way that again, the success of the trusts across West Yorkshire to not have to send people there in the initial phases is because they manage the staffing and their workforce as well as their estates to enable those patients to remain more local where it was needed there. So I think there's been great success with the trust to actually not have to use the place, but it was great success to get it set up. And it does have possibilities to be used in different ways, as you said. So I don't think any of that's been discounted, and we're learning from what happened in the initial phases. I don't know if Ian or Anthony want to add anything to that at all.
No, I think that's a good summary. I guess the point from a clinical perspective is that if folk need critical care, they're better being in a hospital. I think because of the that you've got around them, and it was established as a safety valve facility in a worst case scenario, and as James said, unfortunately it wasn't needed, and we have put it to some use around the CT capacity that we've talked about, and it remains there as an opportunity if we need it.
I suppose the only other thing I would add, if I could, is that the way it's actually constructed and configured means it's only suitable for quite a limited type of inpatient care and support. So it's more than a field hospital, to use that language, but it's not. It doesn't have the facilities of a full hospital. So as Ian said, the best place for people is in a proper hospital setting, if we can accommodate that. If we really, and colleagues will remember that the Nightingales were developed at the stage of the pandemic where the experience from Italy suggested the NHS might be overwhelmed by demand. So if we got to the situation of being overwhelmed, not being able to accommodate all of the COVID care in hospitals that we needed to, then the facility could be used and would be used effectively for that. It would be used for the least complex cases, allowing those with with high dependency to continue to be treated in hospitals with access to ITU or HDU capability. So we'll continue to plan for it to be used as effectively as possible. I think it's more likely, if we do need to use it, it will be about more the sort of use it's being put to at the moment. But fingers crossed that we'll continue to be able to cope without having to bring it into active use.
I'm much more reassured by what you're saying. That does sound a much more appropriate use for that kind of facility, and it fits much more with the experiences that was where these were successfully used in China. Thank you.
Thank you. Yeah. Before I bring in Councillor Rhodes, Councillor Clark, is there anything you'd like to comment on there? Or?
No, I thank you very much for the answers, and it's good to know that it is being continued until March. But it's just for those of us who have been involved in the NHS for many years to now have a facility that is not being used, where we have a shortage of beds in North Yorkshire and have had bed closures in the past and hospitals cancelled. It seems a great pity that we're not using it, but it would be helpful if we could use it for some way of doing less important things and saving the use of acute hospitals. But thank you very much.
Yes, thank you. So, Councillor Rhodes, if you'd like to come in now. Thank you.
Thank you, Chair. Thank you from Sean Ian for me. Can I go back a few points to me? First of all, in the report, Ian said the difficulty to staffing because some staff were still waiting for test results to come back. What is the average time for test results to come back to enable staff to get back to work? That's the first question. The second one is we've had a discussion about the flu and vaccines. And we did see a programme where questions were asked about how the GP practices basically place an order for flu vaccine. And it was based on the assessment of the previous year's figures, plus that would be going into the senior year and then be able to get the injection. And bearing in mind that the Dr. J also said various types of vaccines, the government indicated that it would be eligible from 50 years onwards. Well, the practices I'm aware of and being consulted about, the 50 years onwards not been an option, even those with underlying conditions. And therefore, I have grave concerns about the winter pressures from flu and what are in place to deal with those winter pressures. I know local authorities and the trusts are working together. And for the flu vaccine, when is it anticipated will be more generally available? The other points in the report that I'd like to draw attention to, Chair, is paragraph 23. Significant pressure has increased demands for tests and limits on capacity for requiring tests locally. Can Ian tell us anything that has happened in terms of increasing capacity locally with the increased demand identified in 23? And as for the report on item 96, it says care homes was in place have not yet reached the planned frequency of weekly tests. Can you bring us up to date? Because apparently this time around we were going to deal on our care homes and our care as well. So I'd like to know, being as that was made in the paper here in the report, what happened about increasing that weekly frequency in our care homes? Thank you, Chair.
Thank you. There was some problems hearing you, Councillor Rhodes. You were breaking up quite a bit. I don't know whether
didn't get any of that. I'm really sorry. I didn't get any of that. I don't know whether anybody else.
There was something about paragraph 23. There was a question about paragraph 23 about
I think
the testing.
The councillor's question, sorry, Chair, I think Councillor Rhodes' question there was about the time for results on testing to be returned. If I was able to piece it together, so let me just try and offer something on that and see if it's anywhere near what the councillor was asking. So and I should say there's a bit of a difference between the turnaround time for tests which are delivered in NHS labs. This is what's called Pillar 1 testing, which is mostly focused on testing for patients in hospital or coming into hospital and staff, NHS staff. And the testing under Pillar 1 normally is able to be turned around in terms of the result coming back, within the day, within hours. If I turn to Pillar 2, this is the national programme of testing through, the drive-in regional testing centres, the satellite sites, the mobile units, etc. There's been as part of a national programme, an ambition or an expectation for results to be turned around as close as possible to within 24 hours. So what happens here is, the swabs go off to labs in different parts of the country, what are known as the lighthouse labs and other services. And early on in the programme, in the pandemic, those tests were taking 48 plus hours to return. That was brought down to something much closer to 24 hours on average. I think in recent weeks we have seen that the pressure on testing and the increasing demand increase those turnaround times. But my understanding is they are starting to come down again. So I don't have precise figures to be able to share, I'm afraid, because this is all part of the national programme. But they are coming back down to something a bit closer to 24 hours on average. And obviously, the timing of those test results is really important in terms of people's ability to isolate and respond to them. So we're keen for those results to be available as quickly as possible. So perhaps also worth saying, new testing technologies are currently being tested and rolled out, which are more rapid testing. I'm sure members will have seen some of this discussed in the media. So I think over the weeks ahead, it's likely we'll be moving towards a different testing landscape where we have much more access to rapid testing and rapid results. So I hope that was at least in the ballpark of Councillor Rhodes' question.
I think
on that one, yeah. Sorry, James, would you like to come in? Did you catch any of the questions?
Yeah, I caught about the immunisation then. I think someone's kindly put it up as well there. So I think what is highlighted by Councillor Rhodes is true, if I caught it, is that GPs, in terms of planning for flu, look at their patient lists. They look at the numbers from the patient list from people with chronic diseases and base it on that from last year and what they've got on their lists at the moment there, and they order ahead. It's always the case that way. This year, obviously, there's been the increase in both in terms of we'll probably have increased uptake because of what's happening, but also in terms of the different age groups that will have been pushed this year in terms of over 50s there. So I think there is an issue, as we mentioned before, about making sure we've got the supply, and again, that's been looked at across from West Yorkshire with our group that's looking at immunisations there to ensure that we've got supplies for the region there, and that comes from different sources there. The other issue I think you highlighted was about the over 50s, and I think in a way that's one of the new groups as a GP is one of the new groups that we're managing this year because of COVID there. So in a way it took us a bit by surprise, and I say that in inverted commas, but in terms of because we'd already ordered there, but we're getting those orders in. And I think what you'll probably find, and as a GP I know we're doing that, is prioritising the initial people with the chronic diseases who are who would normally have the flu vaccine there. And then the second stage would be those who don't have chronic diseases, who are additional, who are over 50. We would look at them. I mean, each practice will do it differently depending on their supply numbers they've got there. But I think I know that places are doing that. But it will probably vary a little bit, I suspect, depending on what supplies you've got and the numbers you're dealing with there. But you have highlighted some of the challenges that were coming up. But I think we're trying to meet those, and I think we are meeting them. But they are still challenges.
Thank you very much, and it was very difficult. I don't know whether we've now lost Councillor Rhodes, but it was difficult to hear us. So thank you very much to James and Anthony for those answers. Rachel also wrote something about the flu vaccines in the chat if people want to have a look. I'd like to welcome Councillor Soloway. Sorry, I've only just welcomed you now. You've been in here nearly an hour, but you would like to ask some questions. And then Councillor Greenwood, you've got your hand up as well. Councillor Soloway.
Thank you, Chair. First of all, I want to just mention the fact that while we are all here, our frontline staff are out there dealing with all the issues that this pandemic and beyond have thrown up. And I just want to sort of put out my absolute admiration for what they're doing and what they've been through. Many of them have become infected. Some of them have sadly died as a result of this virus. And I just want to put that out there, first of all. Secondly, I wanted to make a point about shielding. Well, when I'm talking to some of my constituents, I think they are going to be the next group who may well actually start breaching guidance on it, because they've seen they've almost been given some freedom that they're not going to want to give back. And I even know 90-year-old people who are saying to me, I'm not being locked down again, I'm taking my chances. And that is going to be quite a difficult thing for us to deal with. What I do find very, very encouraging is that the survivability rate of COVID has very much improved, and that's down to treatments, it's down to really hard work, it's down to research, and again commending the medical profession for responding to this crisis so well. My final point, I suppose, is there was an initiative earlier on in the year, and our Prime Minister made a very big thing out of it in terms of tackling obesity, which is a crucial factor in survivability from COVID, and it seems to have disappeared off the radar a little bit. Medical staff I speak to say that obesity is the main factor in your survivability with COVID. Many people who die of COVID are obese, and we need to have a national strategy brought out, not just for dealing with this pandemic, but for dealing with the future health of this country. And it seems to have disappeared by the wayside. But back again, NHS staff, I think, have just been absolutely superb in how they've handled this pandemic. I can't express any more admiration, really.
Yes, I think we'll all echo that. Ian, do you want to come in?
Yeah, I mean, so I think we'll bring Rachel in to talk about the shielding. On obesity, it remains a priority for our partnership, and James can talk a little bit about that. I think this point around survivability, we need to be really careful. I don't think there's any evidence that, or there's no strong evidence that there's, and James will be able to comment more, that it's a less virulent or problematic virus, and when people get it, unfortunately, a proportion of them still die. The risk factors that you talk about, it's really important, but I think we just need to be really careful with the messaging on that, because I think there is a view out there that actually it's changed, and I'm not sure that's the case. It's potentially not a particularly helpful message. Okay, James, I don't know.
I suppose I was just going to come back in terms of the physical activity. That's absolutely a big priority. In fact, we're kind of about to re-emphasize that, given what's going on currently in terms of really embedding physical activity across the partnership. And we've got links that we're looking at in terms of helping people get motivated and kind of working with kind of Active Yorkshire, so that kind of everyone is active every day and kind of improve their health through activity there. So Yep, you're absolutely right. It was highlighted early on in the year. It's been on our radar, in fact, doing lots, and it has consistently always been there. But I think we're re-emphasising it. And I was at a meeting yesterday in which that was highlighted, and something that as a partnership we're going to be strongly supporting and putting out there, and ensure that kind of we have senior leaders and real strategic buy-in to this. So we have physical activity champions. It contributes to our 5-year plan as well, and that is part of everything. Whether it's kind of living in good health, it's in mental health to try and reduce our suicide rates. It's childhood obesity there. It helps with in terms of also with our climate emergency as well. So it's in and amongst everything there, as well as being kind of crucial here at the moment in terms of with COVID. So absolutely, Councillor Soloway.
Could I just comment, Chair, on Councillor Soloway's point
yes,
as well?
Absolutely.
I think, thank you. I think Councillor Soloway, I think the point you were making about survivability, if I understood it, was that I think there is evidence that, you know, if people do catch the virus and require hospital care, there is evidence that obesity is actually a factor in, you know, in survivability. You know, once people, for example, you know, have the most severe levels of the disease. So I think that does absolutely amplify the point you're making about the importance of this, you know, of the obesity strategy, which Ian and James have talked about being a key priority for us. I think also that there has been some further national news on that over the summer in terms of the national government strategy around obesity. So I would certainly agree it's something we all need to continue to focus on.
Okay, Councillor Soloway, did you want to come back quickly, or is it being cleared up? I see in the chat before I go to Councillor Greenwood.
No, just the point. I don't think the virus is any less virulent. I just think that the treatments that we have very, very quickly discovered and almost worked on the hoof have. I mean, there's an article in one of the national papers today, a very popular paper, that's saying that survivability of COVID has improved pretty dramatically. The problem is with that message is that also sends out a wrong message that it's okay if we catch it because they'll be able to sort it out. And that is the problem we have got. There has been so many mixed messages throughout this pandemic, and I don't think our country is unique. I think it's just hit everybody really hard, and we've all had to think on the hoof. But strong messaging is really crucial, because if you put out the message that actually it is more survivable, not because it's less virulent, but we've got better treatments, that also makes people complacent. And I think that we will have a difficult winter, not only with dealing with the virus, but actually dealing with people's behaviour and trying to enforce it, which I really don't think we're going to be able to do. I think we're going to have it very, very difficult.
Thank you. It is going to be very difficult, and people are planning and working really hard to make sure that the messaging is the most important aspect of that. I'm just conscious of time, but I'm going to bring in Councillor Greenwood, please, and then we'll move on and let our NHS colleagues go. Thank you.
Mine's just a really quick one, but first, thank you for that clarification, because if I'm honest, I genuinely thought that it was less virulent, and I'm actually telling people that because that's what I've heard, and I thought it was true, and there's less people dying, and so I'm pleased you've clarified that. Mine's a really quick one, actually. It's just something that I've just thought of now. I took my mum this time to get her flu vaccination last Saturday, and they were asking people if they were British. Now, my mum's Italian born, but she's been a British citizen since the 1950s. And now I know they weren't singling her out because they asked the gentleman before her and they asked the lady after. So I just wondered why, what difference that would make, and what would happen if she wasn't. I just found that extremely disturbing, actually, I have to be honest.
I don't know.
That's really interesting.
So I obviously I can't comment specifically on that. I just wonder whether it's because they're trying to get the kind of ethnicity data, and maybe British wasn't the right word to have said in terms of that. But I wonder whether it's that, because I know, again, if we're more informed, then we can target people, not specific with immunisation, but in terms of this, but generally. So I think having knowledge of data or in terms of ethnicity can help us in terms of how we target our approaches, and it helps us in terms of highlighting with research, and then that informs how we then practice. So I wonder whether it was that. British may not have been the right word to have said, but
Well, it definitely wasn't, because just because she's a British citizen doesn't make her less Italian, does it? So I just thought it a bit strange.
Sorry, can I come in on that? Sorry, for the last 2 years since the hostile environment came in around access to treatment in the NHS from people from overseas, it is a standard question that gets asked in all clinical settings, which is, how long have you lived in this country? So it shouldn't be, the question should not be, are you British? It's how long have you lived in the UK? And then if there's just further eligibility checks that come after that. So that's a fairly standard question, and it gets a lot of people by surprise when it's asked, because it's always a confusing one. But that's the reason behind that question.
Well, that is definitely the wrong question in that case then, because I said yes, she's a British citizen, but that then should have flagged up, well, where were you born and how long have you been? It shouldn't say it really. So that's the wasting everybody's time there, really, I think.
Yeah.
So perhaps that message needs to be given out to GP surgeries.
Yeah, if colleagues could take that back, because being British doesn't mean anything really in terms of, because I was asked at the hospital how long, and it is, you're right, Rich, you're absolutely right, it's a standard question, isn't it, that how long have you lived in the UK, and have you been out of the UK for whatever time. But, you know, my dad's a British citizen, but he won't consider himself British. He's Irish to his toenails. So it's been a British citizen since the 1980s. But it's, it's the wrong question to ask that. Yeah, it's about getting that messaging right again, isn't it? Right, thank you very much indeed. It's been a really fascinating, really comprehensive 2 hours, so thank you very much. We're going on to the work programme now. I don't know whether Ian, you want to stay for this, but
I'd be very happy to, if that would be helpful.
Yeah, it would be, if you don't mind. I really appreciate it. But in terms of our NHS colleagues, thank you so much to you know, for giving up your time this morning to come and speak to us and explain things so clearly. And yeah, it is about us now going into our communities and you know, and getting that messaging right, etc. So, and we'll look forward to seeing in the November's meeting. So thank you very much.
Thank you very much.
Thank you.
Cheers.
Thank you. Lovely to see you all. Can I move to Mike now to talk about and introduce the work programme item, please, Mike?
Yes, thank you, Chair. I'll be as brief as I can, because I know we've got beyond beyond 12 o'clock. The first item I put in my brief report was about the workshop, so thank you for everybody who was able to attend that, and thanks particularly to Sally Warren from the King's Fund and her colleagues for facilitating it. I've only had positive feedback about the workshop. We do have some actions to pick up, and Helen Gray from Leeds, who's in the background of the meeting, has kindly offered to arrange the meeting between Councillor Hayden and Ian and myself and Rachel and whoever else needs to be involved, and we'll get that sorted out in the next few weeks. And one of the other issues I think that came out of that meeting was the value from time to time, perhaps a couple of times a year, in having an informal meeting to look at some issues perhaps in more depth and in a less formal way than we do in these formal meetings. So we'll also pick up that and come back to the next meeting with some discussion about that, if that's okay with the committee. One of the things that did come out of that meeting was a request that we shared the work programmes of the 6 local place scrutiny committees, and we put those out with the papers today. I noticed that we managed to not put headings on all of them, but they're listed in alphabetical order of local authority, and I think you'll be able to tell from the change in font and style which is which. We did have a discussion at the workshop and have had a discussion elsewhere on what I've headed, diverse voices, And as we mentioned, I think in the pre-discussion, Councillor Hayden and I are joining the Health Watch Chief Executives of West Yorkshire, who meet together from time to time in October to discuss their attendance at our meetings, bearing in mind that we don't want to compromise work that they're involved in. We will also give more sort of explicit thoughts to who else ought to attend discussions, so that we can make sure that we hear the voice of patient and diverse communities more often when we're discussing issues like cancer. And I'm sure that Ian will be able to help us with that discussion when we meet later on in October, and would welcome any suggestions about how that could happen. I think certainly the committee, perhaps asking someone with some detailed expertise when we're talking about a detailed subject would be helpful. We've already touched on in the chat that we discussed previously having a discussion on health inequalities at the November meeting, and Ian suggested that the timing of that was helpful. And so we will put that, if you agree, on the agenda for November. Councillor Hayden sent out a sort of a bulletin following the last meeting, a little bit after the last meeting, which mentioned health inequalities, and the suggestion that we ask each of the 6 local scrutiny committees to input to that discussion. And if you agree with that, I'll contact the chairs of those 6 committees, some of whom are you, to make sure that we can get an upward feed into that discussion from local places. I also wondered whether, and I think Ian and Anthony may have referred to the work that Owen Williams has been doing at a national level, whether there might be some value in asking Owen Williams from the Calderdale and Huddersfield Foundation Trust if he would be able to join that discussion. I can see Ian perhaps wanting to come in on that, I don't know. So I guess our objectives for that discussion would be for you to assure yourselves that the West Yorkshire health and care system is working vigorously to reduce health inequalities, but also to discuss the issue, or to consider the issue that came up in your workshop about what should happen at local level and what should be considered at a West Yorkshire level. I've got a couple of other items, but if it's okay with you, Chair, I'll pause, particularly if Ian wants to come in.
Absolutely. Ian, did you want to talk about anything there?
Yeah, I mean, like I said, would be really up for that conversation on inequalities in November. It'll be helpful, I think, and it is a real focus for us, and it's something that we've not considered together in scrutiny, so I think it would be a good time. I think the 8 priorities that Owen's work identified are being routed through our programme. So whether it's Owen directly involved in that, or whether we ask the sort of the programme leads, which are Robin Tuddenham, James Thomas, who you've met, and Sarah Smith, to come along and speak to that. I think either way we can manage it.
Thank you. Councillor Smage, did you want to come in? I saw your hand went up. Thank you.
Just really quickly. I think it's a really good idea to hear views from different communities, patients and service users, dependent on the topic that we're discussing. Just when you're looking at that, experiences might be different across West Yorkshire, so we just need to make sure that we're hearing from people across the different areas as well. Okay, thank you.
No, that's a good point. Very good point. Yeah, I think that'll be a really good discussion. So, Mike, did you want to?
Yes, thank you. There were just a couple of other points. I mean, I think one of the issues in terms of the organising the business of the committee is just to point out we do still have a vacancy, Councillor Smade, from Kirklees. So you're here on your own at the moment. To say that if it was, I know Councillor Hayden produced a bulletin after the last meeting. I would suggest it's quite useful to put a little bit more information out about what this committee is doing to each of the local committees. Just to let you know that Karen Coleman from the partnership has offered the opportunity for Councillor Hayden to write a small piece for the weekly bulletin, I think towards the end of October or early November. So that'd be another way for the work of this committee to be publicised. And finally, I think we've had more technical difficulties today than we've had at previous meetings. Certainly, I've heard people breaking up. My detailed technical advice to this committee is it's probably one of those things, but Carol and our IT people will have a chat about this to see whether there's anything that that can be done. So that's that. I don't know if you've got anything to add, Councillor Hayden. Sorry.
Yeah, sorry. Did you remember? Yeah.
It was actually the sort of, I think you were going to comment, Councillor Hayden, about the parallel piece of work on vascular.
Yes, just wondering where we were at, and well, I know where we're at, but where we are, but whether we're having another meeting or what was planned, Councillor Smage and Hutchinson.
Yeah, I think we're putting together another date. We're looking to see when clinical colleagues will be available, but we're bearing in mind that people didn't want clinical colleagues to come out unnecessarily to a meeting, but we need to arrange it so that they would be there if we needed them. Do you know what I mean? So
Right.
Dates are being arranged when they can attend. Okay.
Okay. So it was definitely decided that you needed will this be the final meeting of it, or? Yeah. Okay. Right. Thank you very much. Councillor Rhodes.
Thanks, Chair. Let me get my...
Oh, we can hear you nice and clearly now. That's... Oh, no, we can't now. You're on mute. Oh, no, she's on mute.
You're still on mute, Councillor Rhodes.
There you go.
Yes.
I'm sorry that my system let me down. I had to leave halfway through the meeting. So, well, on the last questions that I asked, I didn't hear the answers, particularly about the care homes, but the system broke me off at the point, so I'm back again. I just want to make a comment, if I may, Chair, and I know it's been a long meeting and a very interesting meeting in many ways, in the information that we've been given and the follow-up that we need on the questions as soon as possible from those that have been asked to give clarity on questions. Mike said about the work programmes and to see where the West Yorkshire fits in with the local agenda. I think we've got to be very careful in how we look at that as in the broadest context across authorities, because yes, there are issues that cross over boundaries into other authorities, and I believe that's where the role of the West Yorkshire Joint Committee comes in. COVID in our work programme seems to be a common theme across all committees at the moment, as well as other issues. But I do think that we've not got to give the impression to the local scrutiny committees that their role is usurped in any way at all in identifying what is local and what we can spread and share across other authorities, Mike. Thank you.
I think, well, I wouldn't want any local place-based scrutiny board to be usurped in any way. I certainly wouldn't want it for my board. I think where we were looking at what came out of the workshop was looking at the, and people can correct me if I'm wrong, is that to avoid any duplication that might be happening at local place, that we don't then take it on, you know, West Yorkshire. So we're just aware of what we're all doing across in our own local areas. But I don't know whether you want to comment on that, Mike.
No, I completely agree with Councillor Rhodes that isn't the intention at all. It is about the duplication, and it's making sure that where there are West Yorkshire-wide issues, people like Ian and his colleagues aren't asked to go to six different authorities to have the same discussion when it can be done here. But that it's really important that the local stuff is done locally. Absolutely.
And isn't it the case that we're building up from local rather than trying to usurp? Isn't got a sense of where the 6 authority or the 5 authorities are with their plans? You know, it's doing it so that we don't duplicate that. It's identifying potential gaps or things that we might do once.
Yeah. Councillor Soloway's mentioned in chat that North Yorkshire County Council are moving over to Teams. I think, well, Leeds are using Zoom. I think we all kind of local authorities and different organisations use different platforms. It's about just, I think we settled on Zoom. I don't know whether Carol or Mike in terms of
At the moment,
platform we're using?
Halifax are, sorry, Calderdale are very new to Teams. We are introducing it, but it doesn't seem, it has its own issues, and Zoom is very acceptable for a meeting like this, where we've got lots of people coming in from different areas. I think that we would struggle with Teams at this stage. It's something that we might be able to consider going forwards. We are also considering at Calderdale in very early stages of doing so, looking at other options, whether I forget the name of it now for the minute, but it's a system that we used to use for publishing, for streaming videos and so forth, but of the meetings in the town hall. Public Eye, thank you.
We found Public Eye very problematic. They've always done our full council meetings, so we decided, and actually for chairing a meeting, it worked for my Scrutiny, but when you've got a lot of people in the call, even though we have a lot of people, but for full council, it just couldn't cope at all. But we've got 99 councillors plus officers, so it's, yeah, there are problems with them all. I don't particularly like Teams. I've got a governor's meeting on Team tonight. And for chairing, I like to be able to see everybody, and and Zoom is much better for that. But we'll constantly keep it under review, as Carol says. Okay, are we about done then? So that was really good, as Councillor Rhodes says. It was really interesting, and a lot of clarification there, because we're living in really strange times where, I don't know about other people, but you get phone calls saying, can I do this? Can I do that? But people are, and it's like, I don't know myself, a lot of the time. And people from all over asking, what they are and aren't allowed to do. So it's great to get clarity on a lot of items. So in terms of the next meeting is, Mike, on the 3rd of November? Have I got that wrong? Oh, you're muted.
Yeah, I can't remember. I'm just trying to find out. I think it's towards the back end of November.
Back end of November. I'm mixing up with my own Scrutiny board there. I apologise. So thank you very much for this afternoon.
I've got it as the 24th of November. 24th. If that's any help.
Yes, I think the 3rd is my Scrutiny board in Leeds. So apologies about that, dear. 24th of November. So thank you all very much, and yeah, take care of yourselves, and keep everybody safe. Molly's landed. My brother sent me a text message. She's landed in Turkey, so not jealous at all. So the rain falling down, and I'm going to have to put my heating on, and it's not even October. Carol.
Sorry, just one more point. Are we happy with the pre-meeting, how it went today, that we do that going forwards?
I think it's...
Sorry.
Yeah, I think it's really good to, we didn't have as much time to talk about the meeting as I would have liked, but I think it's really good to have that time to get people online and check that everything's working, before we go live. So yeah.
Okay.
I'm happy with that. Yeah. Okay. Thank you very much.
Thank
you. Thank you to Carol and Mike and Helen and everybody in the background working away. I really appreciate it.
Thanks.
Thank you.
Stay safe, everybody.
Bye. Bye.